So what was the yes, no, yeah? Are you just following up on Sam B's comments there? So, all right. Everybody there? You're putting Sam down. Okay. Okay. Sorry, this, the cyberbullying that we've got it going on here. So, all right. Who's working this weekend? Anybody? All right. Good. All right, good. Well, everybody be careful. Everybody else is out partying. Stupid people are be out. Please be mindful. Please be diligent. Whatever you guys are doing this weekend with that, okay? So let's go. You guys have been watching the videos and everything else like that. And, please realize that ACLS is traditionally run in a 16-hour course in a classroom where it's a combination of bookwork, videos, a little bit of lecture, and then most of the time is skills labs. Please realize that, while a lot of facilities require practitioners to have ACLS, please realize that ACLS does not teach people to intubate, does not teach people how to use the monitor. It gives them a general overview. But for us, it's very different because PALS and ACLS, in the fact that is the core of what we do when we go out and respond emergently with that. When you go into the ER as a medic, most ACLS and PALS classes are taught by medics because this is our wheelhouse. This is what we are good at, controlling a scene, having a systematic approach. Every one of you, and I've talked to you guys in class, every one of you has worked a bad arrest. Can I see a response from individuals where you have just walked in? It could be in the hospital, it could be on the unit, it could be in the field. Somebody has worked a bad arrest. What are some of those? What were some of those experiences like? If you want to go ahead and talk, go ahead.
Communication breakdown is paramount. And I'm not trying to, I just think that like the one thing I prided myself on when coming into medic school was I was going to never be the person that was yelling at people on scene. I was going to try to keep it as organized as possible. That's the one thing, that's the one negative experience I've always had on certain cardiac arrests, was that it was always just yelling and people not, and I think it's that fear yelling of people just not having control over the scene.
Now, Sam, have you worked without me going and looking at your thing? Have you had an arrest as a medic student?
Yes.
And how did that go?
I think it actually went relatively well. I think it helps knowing that you have a student on board, so it has to be organized. But I think that I've been at Brandywine for the majority of it, so I like to think that they're very educated in what they're doing. So it went really well. I think the key of it, and most of the people at Brandywine have had years of experience, so it's just that experience and being comfortable with having that arrest. I think you can tell the difference in providership based on the year's experience. And they can either go one of two ways. And I think everybody can attest to it, that it's either going to be pretty smooth, where the person knows every step that's going to come after the first, and everybody's on the same page, or nobody's on the same page and it's a yelling match, and cords are tangled and there's nothing that's organized, and it can just go one of two ways. There's no in between.
Okay. Anybody else have a? Anybody else have anything they want to discuss? Sean's never been on an arrest that was a disaster scene, right? But as Sam had said, communication, but also, there's one chief and Indians around. And one of the things that you have to learn how to work is, one, knowing who the chief is and how those directions, and that's what that one video talking about one-way communications, repeating your order to where make sure everybody's got everything. But that also comes along with, a concept, span of controllability and all the whole NIMS that we guys that is in our head. Can we delegate? And as a medic, one of the things, please realize, and you guys have figured this out too, we can't do everything. I know and I know you're rolling your eyes at me because some of us are control freaks and want to do everything. All right. It's sometimes we have to learn how to be able to, delegate that authority in your integrated out of hospital experience for the National Registry. That you will be given. You will be paired up with a paramedic practitioner, a professional paramedic practitioner that has all of the skills and knowledge that you have, but will only follow your direct orders. So if you tell somebody, hey, why don't you go ahead and get an IV? They're going to do that in the way that they see fit using their scope and their skills. But if they're not doing it your way, there may be some friction there. So that's something that goes along well, and you'll be graded on that as well. I know when I took mine, the practitioner, the professional partner, was told to miss 3 IVs on this patient. And after the third one, I had, tongue in cheekly looked at the person. I said, you and I are going to have to talk a little bit about your IV technique. But that was seen as a negative toward me because I was bullying. I'm like, no, I wasn't. You missed 3 IVs. You would expect, 1, okay, 2, but your third one. But what they wanted to see was how I handled that issue. Gave the paramedic partner 3 attempts. I said, okay, it's not really that critical right now. I'll do it in the back of the truck. So they look at that and they measure you and they see how you deal with that. So please realize with that. But again, it's one of those things. Working with a partner. I mean, how many of you guys work with regular partners during your shifts, working as EMTs or AEMTs right now? Do you like working with those individuals? Okay, thank you, Tori. Uh, okay. Sam has the same partner. So do you guys get a repertoire? And despite the fact whether you may or may not like them personally, you have to have a professional relationship with them. Rager, I got a question for you. Working down where you work, you're on an engine with 3 other people. Is that right? And you respond to medical calls?
So I'm on a rotation. So I'm on the ambulance for 2 shifts, and then I'm on the engine for 1. So we have the same partner every other shift, just about.
Okay, but
And
on the engine, you run with 3 other people, right?
yeah, we're a paramedic engine, so our lieutenant's the paramedic, and we have ALS equipment on there to be a ALS provider on a medic crew.
Okay, so you end up dealing with a lot of different personalities, and let me ask, how many of you are A-type personalities? Closeted A-type personalities. Sam Grimm, no. You know what, Sam B, I don't, honestly, I don't see you as a type A. I see you as a type AB in that manner. You're much more politically, you have much more political awareness than most other people. So Sam, I see as that type A. Sam B, yeah, it's an AB to a certain point. What about you, Brandon? Only way when you met person. Okay. Okay. Thanks, Mort. I appreciate that. Okay. Tori, we already know Tori. With that. But again, most of us tend to be type A in that manner. Or as Brandon said, only when, real laid back until it needs to be. But again, in these situations, you're going to be, in a couple months here, hopefully you're going to be walking in and you're going to be the individual with the plan. And you will have individuals out there who will question your, I don't want to say authority, but your medical oversight and your running of that scene. That's something that you have to have confidence, but not arrogance in that. And that goes along with the growing part. If you walk in and you're the best thing since sliced bread, you're going to get cut down real quick. But if you're humble in that fact and you take criticism and everything else, it'll make life much easier for you. But again, having that overt type A, and as Sam said, screaming at other people and stuff like that, I will tell you, as working on a response team for all those years, I never had the same partner any night I went in. So it was the uniform that allowed me to have that oversight, because there's the pulsar medic. Okay. Whereas, never having a regular partner will come into. But again, when we look at that systematic approach that the ACLS video talks about, please remember we have to worry about that the ERs and the ORs and other places don't have to worry about is we have to worry about that scene safety, that situational awareness. There are times where you may not be able to do a skill that you need to do or think it would be beneficial to your patient on scene. You have to get them up and in the truck as quickly as possible because you have to control what is going on. I've always been a fan of, assess them, fix the life threats, and then get them out to the truck as quickly as possible, because I can lock the doors. I can move away from a scene or something like that. That's something that some people don't really understand that, but being situationally aware, all those oral stations, scene safe, BSI, jazz hands, number of patients injured, am I wearing proper PPE? Should I consider, or, do I need the backup? These are all questions that, while they're redundant, it's very important for you in the back of your mind to constantly be reassessing the situation. Okay, I did A, B, and C. What do I have to do now? Oh, I forgot. Well, let's go back and reevaluate A, B, and C really quickly. So that's what these first four things are here in this slide set, in the fact that, always ask yourself, the situation can change. A situation is, a scene is not static. It is a dynamic situation, but you as the healthcare professional are now, as the medic, not only responsible for the patient and your safety, but you're also responsible for your patients. All right. And sometimes that does extend out to the people surrounding your ambulance, and everything else like that. So constantly reevaluate mentally. Everything okay? Everything okay? What can I do better? Okay, what should, this is working really well. Why is it working well? Let me put that away in this little nugget and just move forward. Hey, let's ask. Remember, asking for help is not the sign of a weakness. Some people will tell you that, and it's not. And those are the ones that have problems with things. And I from a personal standpoint, I will tell you, being that aggressive, arrogant personality can only cause you detriment to your patient, to your partners, and yourself. All right. So just constantly reevaluate and ask other people's opinion. Hey, how'd that go? Sit back with your partner at the end of the day. Tori, yes, even though you may not even like your patient, your partners, sit back and ask them at the end of the day, hey, what worked good? What didn't work good? Pros and cons. If you were a scout, you sat and talked about the roses and thorns. That was what my troop always talked about. Hey, what was the rose part of your day? Hey, what was the thorny part of your day? And you can only learn from it, and that will add to your tool chest going down the road. So again, when we walk up in that systematic approach to working these types of calls, it all comes back down to, are you safe? Are you aware of what's going on around you? How many patients do we have? Are we expecting any more? And that should go directly in, do I need help? Should I consider backup? Because I think Sam Grimm, we had talked about that in the case study previously. Do you need backup? Well, for what? Well, what happens if this case is bad? What happens if that patient was 600 pounds? So all those things make you question what you need to do. Today's era of COVID-19, Okay. Proper PPE. You know, I can tell you, reading some of the national paperwork and research that's coming out there, the days of wearing gloves, safety glasses, and now a face mask are going to be on every call. So just be mindful of that. It may not be an N95, but it may be some type of face mask along with that. So please remember that all of your patients, every one of your patients from now, from the day one that I met everybody, okay, till the day that your career is over, even then, you should always assess every patient. And I know some of you have picked up that and go to Walmart and sit, or at the, sitting outside the nursing home or the elementary school mart. You assess your patients from far away now, right? We look at individuals and those individual biases that we have. We have to assess the patient. Okay. Assess the surroundings, and always, 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 please remember, check the belly. Okay. Always check the belly. That is the one system that will come to haunt you in your nightmares. Okay. All right, 6 foot. Okay, but not the 500. That's good. All right. So just remember some of the things we talked about last, Monday night. The ab poo. What's your GCS? Use those sample OPQRSTs, deep cap, BTLS, whatever. Just get in the habit of checking your patients. Check the belly. Check distal pulses. Check distal, PMS. Check, flank issues. All that other stuff, because there's nothing worse than running into the hospital, taking care of a patient, and the first thing the ER does is find something that you were unaware of. Check the head, check the belly, all that other stuff. But again, as we start working through those algorithms with arrests and everything else like that, please realize that. All right. Positioning of your patient. Whether your patient is conscious, alert, and oriented, in respiratory failure, respiratory distress, cardiac arrest. Anywhere from the cradle to the grave, from laying down to standing up. How is your patient positioned? And the one thing that we always talk about is airway control, and that's why I put this slide in here under the systematic approaches. How is your patient presenting to you, and how are you going to treat your patient best of all? Are they seated? Are they in that tripod position? Or are they seeking some type of position of comfort that you can't really define, other than saying patient is in a seated position with their head between their knees? That's their position of comfort. They're alert and oriented. They're maintaining their airway. That's good. That's good to be. Okay. So please be mindful of that. The one thing that I do recommend when you're assessing your patients, especially in these respiratory cardiac arrest things, is if you have somebody that is standing and you have this thought that think about what happens if your patient falls. So always try to get your patient into one of those three, if they're alert and oriented, a seated, tripod, or position of comfort, sitting down, to where if they do fall over, they're not going to hurt themselves. Now, if you end up showing up with, one of your excited delirium patients, and you want them to sit down, that may not be in anybody's best interest to do that. But again, if you have a medical patient or even a trauma patient that is needing assessing, try to assess them in a position that is comfortable for you to assess all the way around, but also to make sure, in case something were to occur to them, they don't fall and DFO, hit their head, and an extra report has to be written from that. Now, if you put your patient in a supine position, how are you going to put them? Are you going to put them in a semi-Fowler's? That's usually anything over 20 degrees, but before you hit, 90 degrees, or a modified semi-Fowler's. I've seen different versions, but putting them on a stretcher, laying them back, getting them into a position of comfort. But what ends up happening if we end up having an arrest, or if our patient is medically compromised? And I chose these two photos here to show you the difference here, where if we have an individual that is supine, okay, laying them down, especially if they have a very large chest, okay, and we lay them completely supine on that stretcher, what's going to happen to their airway? What's going to happen to their ability to breathe? All that extra weight, this guy down here, 375 pounds, a third of his weight is located in that anterior chest. he's not going to be able to breathe well. So putting him a little bit up, lifting him up a little bit, this ramping concept, lifting somebody up to where that external meatus of the ear is in line with the sternal notch will help. So that's what's in the ramping position. Here you can see this young lady here being ramped up. The bed's laying quasi flat, but again, we're lifting them up. And think about physiologically, if you end up having a patient that's in congestive heart failure and you try to lay them down, what's going to happen to all that fluid in their lungs? Whereas when you have them sitting up, it's going to be in the bases. But what happens when you lay them down? Anybody? I guess everybody died. All right.
Well, the fluid's going to rest and I guess cover most of the alveoli.
Okay, and then what's that going to cause? No, we don't think that way, Sean. All right. No, but Sean, I mean, think about what's going to kick in. Their fight or flight, and they're going to become oxygen hypoxic, and they're going to want to start fighting you. So as we start moving forward, maybe putting somebody sitting them up, even though you may need, even though Sean said opportunity for a tube or something like that, think about that. Yeah, if they're truly in respiratory failure, you're going to get the tube anyway. Okay. But what we can do is mitigate that a little bit more by ramping them up and allowing, because I'll tell you what, this guy trying to intubate this guy versus intubating her, if you put her in a ramp position or even just like a quasi semi-Fowler's on your stretcher, this is going to be a whole heck of a lot easier to intubate than this. All right. And this is going to be easier for the patient to breathe based on that anterior thoracic weight and being able to physiologically breathe versus this individual here. So think about that down the road. And then the other one is the sniffing position. And the sniffing position is if we are lying completely supine, okay, and we try to maintain this airway. Remember, to get this in line, we got to bring this head up to here. It's back to playing with the airway heads. Okay. Sniffing position is where we take a pillow, shove it up underneath the back of the neck. Okay. We flex the cervical spine. Okay. And you extend the AC joint here, which will allow, with the insertion of your tube and your blade, to get a straight line in there. Little modification. But again, if we're trying to, maintain this 375-pound patient like this, maybe putting them in a ramping position might be a little bit more beneficial. So just think about that next time you start seeing patients. How are they presenting to sit them up, sit them down? Remember, when we start looking at treating patients, we always need to worry about differential diagnoses. Okay, what is actually going on with this patient? And we'll talk a little bit about this in a little bit when we talk about acute coronary syndromes and differential diagnoses. Okay, now remember, as we start moving along, we start talking about assessing our patients and this systematic approach. As I talked about earlier, remember, any of these actions can be done simultaneously or delegated, just like when we started talking, with CPR. Can we assess respiratory rate and a carotid pulse at the same time? Less than 10 seconds, I can look down the chest and I can feel for a pulse. That's simultaneous. Or you have your partner, hey, take respiratory rate for me. I'm going to take a pulse. Okay, delegate. So think about that stuff. When we start working about airway stuff, when you start looking at the quizzes, the tests for ACLS or anything else like that, please remember that they consider suction. Okay, despite the debates that everyone in this class has had with me regarding suction, it's one of those things. I believe it's an essential piece of equipment that should go in on every call, because by the time you realize you need it, it's already too late. So suction, remember O2, according to the literature, according to AHA, should be greater than 94%. But also please take that with a grain of sand, that what if your patient has greater than 94%, but they still look like they're air hungry. Okay. If they have chest pain or something like that, a little isn't going to kill them. And it shows that you're empathetic to your patient. You're providing something to them. Okay. And then when we get to that end tidal CO2, remember that what your normal rates are, 35 to 45. If we're doing CPR, it should be greater than 10. Spike during cardiac arrest means that the ATP is being produced at the mitochondrial level. So how do we end up, just to run through to remind you, how do we run through our adjuncts for giving oxygen? 1, nasal cannula. All right, easiest 2 to 6 liters per minute. All right. You may see out there, whether you're in the hospital, I'm suspecting in the next 2 or 3 years, we'll end up seeing high flow nasal cannula units at home, where those units carry 40 to 60 liters per minute. They also provide some PEEP as well, but you may see those at home. Simple mask is something, and I didn't put the Venturi mask on here, but simple mask, okay, that's just a mask, usually greater than 10 liters per minute, 10 to 12. It's always been used for individuals that can't handle a nasal cannula, but it doesn't have a bag on it. They've kind of fallen out of favor, but it's just one of those things to remember. We have the partial and non-rebreathers, 12 to 15 liters per minute. Yeah.
What are those pediatrics? I know pediatric kids, they have those nasal CPAPs. What are they running at?
You mean are you saying CPAPs, or are you talking about high flow nasal cannulas?
I think they're I don't know, because we had a transport ALS patient, because I know it's not in the paramedic scope to transport, but it was his nasals. It's not like I think there's, because I know like kids can't, not 100% sure what they're called, but it was like high flow nasals, but it's not in the paramedic scope to transport it.
Mm-hmm. Those typically, the ones that I've seen for critical care for the babies, are high. They're high flow nasal cannulas that have a little bit of pressure behind it, just secondary to the actual flow. And those, on the adult ones I've seen, they're usually 40 to 60 liters per minute. On the pediatric ones, typically they're like 20 to 40, but they can be titrated. But those are like stopgaps for patients that need high flow oxygen and high FiO2s for lung injury, or especially on those babies that need a lot of pressure behind it. But it's a stopgap or before the patient actually needs intubated. So those ones there, they basically are nothing more than, in theory, nasal cannulas that they're able to push a whole bunch of pressure through with high concentrations of oxygen. But yeah, it's the same concept, just lower, and usually they'll send nurses or RTs along with that to maintain that, because they're currently not within our scope. You are correct in PA. So CPAP, BiPAP. Pennsylvania, we use CPAP pre-hospitally. And again, we gradually increase our way up. Sometimes we can circumvent doing the very, very basic stuff, based on experience and comfort level. But again, we move up to that CPAP. But please remember, with most CPAPs, and I'll speak from my service, what we use here, those the orange ones, even with a high flow output at 60 psi, with mixing, they're only providing about a 50% FiO2. They're applying 10 centimeters of water PEEP, but they're only providing about 50% of oxygen. So 21% is our normal. It bumps it up to about 50 to 60. So the way to end up getting more oxygen is to put a nasal cannula on underneath your mask at 6 liters. Now you're getting that extra 40%, 40 to 60%, depending on the overall flow, plus the 50, you aggregate that, they're getting probably closer to 90, 95% based on that. So there's ways to do that stuff, and you read all the research, apneic oxygenation and all that other stuff. The next one's going to be our BVM, along with the associated nasopharyngeal and oropharyngeal airway. Remember, dropping 2 NP airways is not a bad thing. It's called the double barrel technique. Please remember, according to all AHA guidelines, a 2-person BVM method is the preferred method for providing airway ventilation. If you end up having a single method, it is the CE method. Also, they talk about, beards and all that other stuff, the 332 monikers and all that other stuff that helps us with that. As we continue going further up, we have the supraglottic airways, the rescue airways, the blindly inserted airway devices. That's, appropriate. Please realize that in the registry and the AHA, they do not separate an LMA out of this breakdown. Supraglottic airway, rescue airway, BIAD, as well as an LMA, even though Pennsylvania doesn't recognize an LMA, laryngeal mask airway, as an appropriate device. When you read your registry, if you do see the word LMA, please realize that it fits into this same category right here. And then finally, we have the golden rule is endotracheal intubation. Please remember that, we have to verify with auscultation. Remember, if we end up having lung sounds on the right side but nothing on the left, we end up having a right main stem. Remember how to remove that. We just deflate the cuff. If it's been inflated, pull it back till we get equal bilateral, equal lung sounds on both sides. Please remember, not only does Pennsylvania, but pretty much across the country right now, there's a big push for end-tidal CO2 waveform capnography to verify and maintain that. So just be mindful because of the whole incident of esophageal intubations. So please be mindful of that. Also, if you're able to maintain an airway with BLS maneuvers, please continue. There's absolutely nothing wrong with that. But constantly consider, I put this note in here, constantly consider 5 minutes from now. Okay, think about it. It's just like driving your emergency vehicle. Okay, if it's right in front of you, it's too late. The provider that is prepared, that's the one that takes care of the patients the best. Okay, what happens now versus what happened 10 minutes ago? 10 minutes ago isn't that we gotta always keep moving forward. Okay, so one of the things and why that becomes important, especially with this systematic approach, and when we do and get ROSC, or if we have to transport our patient, please remember, we got to get these patients up and out safely. How do you get the patient up and out of the house? Yes, I'm well aware of ABC, Airway, Blue Cross, and Blue Shield, and Can You Walk? I'm very well aware of that. Trust me. My back is living proof of that, of breaking, trying to lift those 300, 455 pound patients. And please remember, you have to document this. You're going to go out there and you're going to be an active working clinical clinician. So you're going to be responsible. You and you alone are responsible for the actions of that crew. So if you think that your patient is able to walk safely, and there's research out there, Boston did it, that, patients fared worse with chest pain being carried out of a third-story brownstone in a stair chair versus allowing them to walk out, because the hemodynamic instability of freaking somebody out, carrying them down a flight of steps backwards versus letting them walk down, was equal. Just like running lights and sirens. I just saw a number today where I think 86% of the population that is on ESO does not transport light or sirens. We know what that does metabolically. We know what that does hemodynamically. Running lights and sirens is not good for you, your partner, your patient, or your truck. Because you can control your vehicle, but you can't control the stupid people driving out there. So just be mindful of that. But constantly think 5 minutes ahead. What can happen? May never get there. Hope for the best. Prepare for the worst. And then the other thing is getting EKGs. Please remember, baseline minimum 3 lead. Running a 12 lead is not a bad thing, right? Especially if you get ROSC, you got to run serials. So leave them on there. Okay, and also don't forget, if you think you got right ventricle involvement, okay, get yourself a 12 right-sided 12 lead. Looking at that, but all of this, that 12, don't wait on scene to do this, because again, one of our, get to the hospital definitive care. Sitting around, Sam Grim and Brandon can attest to this, working in the city or close to a receiving facility. What good does the patient if you're 5 minutes away from the hospital, but you decide to stay on scene for 35 minutes if you can't get to the receiving facility in time? So you have to gauge what you're doing. All right. Venous access. I know everybody wants to go for the drill, but in AHA, it's one of those things. There are specific, algorithms to follow. So for an IV access for cardiac arrest, 18 gauge or larger, ACEJ if it's permitted by your local command center, and consider your overall transport access. When you put your patient in the truck, do you have double bench seats? Newer construction, you only have a airway seat and a patient's left side sliding seat. Where are you going to put your IV? If they're going to go to the cath lab or something like that, think about that. Your receiving facility may have rules or regs based on what they do. So, pick up on that. It just don't be what's easiest for you. I will. If you end up in a cardiac arrest, end up pushing a lot of fluids and pushing a lot of drugs, you're going to end up needing that. 16 gauge might be more beneficial for you. But if you're just starting a 16 gauge just because your patient was a jerk to you, that's incorrect. I'll call you out on that. But if you're doing something and it's medically necessary, there should be no reason, and documented as such, with that. Now, in arrest, starting 2 lines is better. Because again, if we end up going to the ER and you end up having to start 2 lines, one has a vasopressor, the other one has something else that mixes. Remember, precipitation. We don't want to do that. So having one line that's your primary fluid line or your drug line, whereas the secondary line is another IV line or your primary drug line, whatever. Just get into a systematic approach where you do everything the same. All right. IO. I know here with Dr. Rehart wants everybody to go to the IO first off. That's his decision. But according to the AHA, they want you to go with an IV. All right. 3 attempts or within 90 seconds. All right. If you can't get an IV within 3 attempts or 90 seconds, go to an IO. But they want you to start those IVs first. So it's one of those things to think about. IO is currently permissible in the proximal humerus, distal femur, and the proximal tibia. And each of these locations have pros and cons. All right, you could we've gone over those. For patients that are in chest pain, 22 to 20 gauge in the distal upper extremity is fine. Okay, you don't have to go AC every time, because again, please remember, if you go in that AC and you miss, you've just blown that entire extremity for any other IVs. Those patients may have to go for TPA. TPA breaks down clots. You've just put a transient hole in somebody's arm. You don't want to do that. So start low, work your way up. That way you have more than one IV start. But again, it's up to you. You're going to know what receiving facility does, and if you assess that your patient might end up having to emergently go to the cath lab, start a second line and on the other side and go with an 18. With that, I know people say, and maybe this is just my opinion, 20 gauge, wonderful. 220s, you can flow the same amount of fluid with 118, but it's just much nicer knowing the surgeons and everything else like that. Given what they have to give, they like that bigger 18 gauge just for the fact it doesn't give as much back pressure with the flow on certain things, especially if you start looking at putting in tandem with Swan caths and stuff like that. All right, and if you have a CVA, stroke or anything else like that, with stroke, whether it be hemorrhagic or an ischemic style, a minimum of at least an 18 on the unaffected side, regardless. All right. So let's talk about some acute coronary syndromes, ACS, and their various subtypes. There's only 3 subtypes. The first one we're going to look at is going to be the stable angina patient. Okay. You also see it called angina pectoralis, and pectoralis is because it deals specifically around the pectoral muscles of the chest. But your stable angina, as defined by, what book was this? I got this from Rosen's Emergency Medicine Concepts in Clinical Practice, Volume 1. is that it is a transient episodic chest discomfort that results from a myocardial infarction. Discomfort is typically predictable and reproducible within the frequency of attacks constant over time. Now, they're usually brought on by either physical or emotional stress, and they usually resolve with rest or nitro. These are these patients that we go out and see that have angina. They took their 3 nitros. It didn't get any better. I came in, drank a glass of water, and cooled down, but it didn't get any better. Okay, so that's your stable angina. These are the patients that have the chest pain. They have the nitro dur, the nitro paste on them. Now, please realize that angina, according to the Canadian Cardiovascular Society, okay, actually has different grades of angina. There's grade 1, 2, 3, and 4. And you can see that this grading scale came out well before you guys were born, but back in '76. And basically, it's just a subjective grading where grade 1 is ordinary physical activity, does not cause the pain, okay? And it's associated with strenuous or rapid or prolonged exertion. That's grade 1. And then when you get down to grade 4, inability to carry on any physical activity without discomfort, anginal syndrome may be present at rest. And this is where we start getting into, in that grade 2 or 3, this transition from what is stable angina, a grade 1, to unstable angina. Okay, and this is where we start getting into grade 2s and 3s and 4s. But UA is broadly defined as angina occurring with minimal exertion, new onset, or worsening change in previously stable angina. Okay, frequency gets more common. The duration lasts longer, as well as its resistance to any previous medications that you had taken. All right. There's some other stuff that goes along with this, especially when we start looking at broken heart syndrome or stuff like that. But again, this is the unstable angina. Now, this is also in the literature sometimes referred to as pre-infarction angina. All right. And any patient that is diagnosed with UA or you end up out there seeing should be considered a harbinger of an upcoming, current, or resolving AMI and should be treated aggressively. All right. Now, if we look at the generally universal accepted definition of the third subtype, which is the AMI, okay, which is defined as myocardial cell death and necrosis of the tissue, okay. And these two, we know all about that. We spent half a year looking at 12 leads trying to determine whether somebody had that STEMI versus non-STEMI. Okay. Please realize that STEMI make up about 25 to 40% of myocardial infarctions. There is this explicit classification system, which I have below: type 1, type 2, type 3, and type 4. And there's a type 5. Did I cut that off? And there's the fifth type, I believe. All right. I cut that off. I'll have to get that to you. But type 1 AMI is those related to plaque erosion and or a rupture, a fissuring, or a dissection of the coronary arteries. A type 2 is related to ischemia, thereby decrease of increased oxygen demand or decreased supply. Okay, secondary to spasm, embolism, anemia. Okay, arrhythmias, high blood pressure or low blood pressure. It's a type 2. When we get to type 3, sudden cardiac arrest. Okay, that may be related to an MI, or the EKG had changes along the way, or there's a blood clot found post-mortem. All right. Type 3 is secondary with coronary angioplasty or stents. This is basically an MI that occurs secondary to some type of instrumentation issue, meaning they go in and they do an angioplasty, or they place a stent, and the instrumentation that the physicians were using caused damage to the heart muscle at that time. And then 4 is associated with a cabbage. All right. But again, here we have, just talking about what's known as the universal definition of an MI as you go along. So you go into the ER, And this is how somebody gets identified as having an MI, the overall criteria. Okay. Cardiac biomarkers over time, symptoms of ischemia, EKG changes. Okay. ST changes or new left bundle branch, development of those pathological cues. All right. Imaging evidence nowadays with the new CT models, everything else like that. Sudden unexpected cardiac death. Okay. PCI, as we've talked about already, and then the grafting, as well as any pathological findings in an AMI. All right. So that is the universal definition of what an MI is. As we talked about earlier, some of the things with the differential diagnosis we need to worry about when we start looking at this. If somebody's complaining of that chest pain, the shortness of breath, the GERD, or something like that, other things that we have to worry about that we got to think out on the periphery. Okay, aortic dissection. All right, acute pericarditis with effusion and tamponade. All right, spontaneous pneumo. All right, or esophageal rupture. These are things that can mimic those that chest pain associated with angina and or AMI. So just be mindful in that you're thinking about worst case scenario, and again, aortic dissection. Now, again, if you're in a thoracic cavity and you're having an aortic dissection, there's really not much we can do with that. But in the belly, you can check it out. Ask the patient if they have a history. Does it feel like something's trying to rip their way through their back or their front? Ask them all that stuff. When we look at patients suffering from ACS, their overall symptoms include chest discomfort, the pressure, the fullness, the heartburn, belching, squeezing, pain in the center of the chest. It feels like an elephant sitting there. Pain with radiation. It can go to the jaws, the necks, the arms, the shoulders. It goes retrosternally. It goes between the shoulders. Do the patient, one of those assessment things? Oh, by the way, are you lightheaded at all? Are they lightheaded? Are they complaining of fainting, diaphoresis, nausea, vomiting, syncope, or anything else like that? That's why anybody that has a syncopal episode automatically gets a 12 lead, just to rule anything out. Anybody that presents shorter breath or difficulty in breathing with or without chest pain, remember how close the cardiovascular and the respiratory pulmonary system are related. Okay, so just be mindful of that. The other big one, especially when you get to the individuals, is denial or minimizing the signs and symptoms. Guys are wonderful for doing this. Oh, no, I'm fine. I just ate some bad fish last night or something like that. No, I'm good. My dad's first, my father, big, tall, tough construction guy, waited 3 days one time for the onset of his first heart attack. Started on a Friday afternoon. He drove 200 miles to his cabin. Hung out, didn't really do too much. My mom said, just kind of spit and sputtered around. Didn't feel really good. Sunday afternoon, finally called his doctor and they said, Rick, go to the hospital. Okay, my dad's 200 miles away. So what does my dad decide to do? In true plumber fashion, my father drove home, loaded the truck up, drove home, took to 3S, shit, shower, and shaved. Got cleaned up, went to the hospital, and ended up having his first heart attack 3 days after the signs and symptoms started. The second time it did, he waited 2 days. And there was about a 10 to 12 year separation between the two. So most average individuals will wait about 72 hours before seeking care if they are in denial. So those are the ones that we got to work hard. If you think, you listen to that extra little character in your, that sixth sense of yours, think about it. So let's talk a little bit about some drugs. Okay. Now in your ACLS books, whether you're looking at 64 to 60 pages, 64 to 66 or 170 to 172, the general drugs that we talk about in ACLS are these. All right. Now the Reiki MD is a wonderful resource to have. He just posted a new one on procaminide. I did update the list in Blackboard, so you guys can go and do that, as well as the your farm books, but some of the ones that you need to know inside and out are going to be adenosine. Okay, we know that that's classified as a miscellaneous agent. Okay, typically when you look at those classifications of the antidysrhythmics, amiodarone, okay, class 3, the 300 or the 150 and all that other stuff, and the drips over 10 minutes. Atropine sulfate, remember the max for atropine sulfate is 3 milligrams. Dopamine, remember the infusion, we're probably looking at 1600 mics per ml, and 2 to 20 milligrams per kilogram per minute. Epinephrine, please remember when we talk about epi at AHA, they're going to talk about the cardiac epi, the 0.1 milligram per milliliter, or the old 1 to 10,000 solution. That's that IV push. They're also going to talk about an epi infusion, but please realize in Pennsylvania, we're doing that push dose epi, 10 to 20 mics per ml. Lidocaine's a class 1B. Mag sulfate, again, a miscellaneous agent, especially with torsades. Nitroglycerin. Please realize that nitro is given in sublingual format, transdermal format, as well as we also may see it if you end up doing a critical care transport or just a transport in Pennsylvania, a infusion transport of the Tridil. Also, please remember when you're assessing your patient, don't forget to look for transdermal patches, your nitro DUR. Aspirin, it is the big one. 81 to 324 milligrams. It should be given on every patient with ACS considerations unless they have GI bleeding or they have a known allergy to it. And please realize that a known allergy to an aspirin is a serious anaphylactic reaction. All right. If you read the ACLS book, they still want you to be given morphine, all right, 2 to 10 milligrams, but they also use the term opiates. So fentanyl's also there for you. In Pennsylvania, they give you the option of morphine or fentanyl. Fentanyl is on top, meaning they want you to use that first up to 100 mics. There is a lot of debate related to the use of morphine. Just so you're aware, you may see it go away because it doesn't show that it does any better, and it may end up having some issues later on down the road if given in quantity. So please realize that, coming down the road, if you're going to take a test, morphine's the ACLS AHA version that they want you to do, but consider that there is fentanyl. There's also nitrous oxide. There's all this other stuff out there for pain related to that. But when we start looking at, and I have a little historical commentary here about morphine, but we'll talk about it. O2, please remember it's based on your patient's overall need, how you assess them, and your SpO2s with that. Benzodiazepines, whether you get into your Valium, your Ativans and all that other stuff, your benzos. Please remember you're going to be able to need that for pacing. If you need to, again, there's some services that may say, oh, let's give them ketamine or something like that. But pacing is one of those things where you will need those benzos. The other thing, I don't know if you're familiar with this, and I know Richie Rush and I've had this discussion for a long time, a couple years now, but there is a issue with CPR-induced consciousness, where based on the quality of CPR that you were doing, your patient may or may not actually wake up as compressions are going, but as soon as you stop, the patient goes unconscious again. It's a limited, very small subset of patients, but it is something that's out there. So don't be freaked out if you ever have a Lucas on or something like that, and all of a sudden your patient has purposeful movement and their eyes open. At that point, it hurts. But if you stop doing what you're doing, the patient's going to die. So you need to be able to sedate them. Yeah. Why don't you ask them what their insurance is too at that point, Sean? But it's one of those things to just be mindful of. Okay, it can happen, and it does happen. And then the other thing, in the hospital, you may see if you end up having a patient that is post-ROSC, one of the things is heparin. okay, where you heparinize a patient to where they don't clot secondary to that blood that's been sitting around in the atria or the ventricles. And there's two types, unfractionated and low molecular weight. You don't really need to know about, but you need to know about heparin, okay, as we move along with stuff with those drugs. And just to give you a little bit of historical review, because if you look at the page of 172 of your book, if you look on the left side of those graphs, where it's of these charts, where it says lidocaine can be given via endotracheal tube, I want to talk a little bit about that and just give you a little historical aspect. So the idea of giving morphine for ACS-related pain is not a new one. Morphine's been given around for years and years and years and years. There is a acronym that floats around there, right or wrong, based on the research, called MONA. MONA. And MONA stands for morphine, oxygen, nitro, and aspirin, which is the old way that we used to instill in ourselves how to treat an ACS patient. Not in that order, but at some point they need oxygen, they need aspirin, they need nitro, and morphine for the pain. And think about the physiological aspects of what's going on. Aspirin to decrease the platelet aggregation, nitro to decrease preload, increase afterload a little bit, coronary artery dilatation, because we need to get oxygen to that. So if we open up more and more red blood cells can get them, we're giving more blood, we're loading the oxygen onto the red blood cell as much as we can. It still hurts. Okay, let's give them a little bit of morphine. One adds a little bit more vasodilatation, but also if you've ever gotten morphine, those opioids, you just calm down. Your anxiety level drops, your heart rate drops, okay? Your systolic, your cardiac output goes up, hopefully. It keeps your brain oxygenated. So that's the whole idea. But again, the research is moving away from morphine. So that's why if I did say it in class, it was a accident. I've tried to get away from using that. The fentanyl is probably better, but if your server doesn't carry it or whatnot, you do have that morphine availability. But again, remember, regardless of what you're doing, please remember you got to be mindful of your patient's heart rate. You don't give nitro below 50. You want that 50 to 100 range, and your blood pressure of 90, as well as nitro. Don't forget asking about ED drugs or pulmonary hypertension drugs. Okay. The other thing is when you look at that drug, it says it can be given via endotracheal tube. Years ago, when I was a young practicing medic, prior to the use of IOs, if we didn't get an IV, it was acceptable for us to give our cardiac medications down the tube. Now, those cardiac medications had the acronym behind them, lean or kneel, which stood for lidocaine, epi, atropine, and Narcan. So we could give those pre-filled syringes down the tube because they were water soluble, and the theory behind it is they go down the tube, they then get flushed all the way out to the bronchioles, down through the smaller bronchial tubes, down to the alveolar sacs, which then, because there's only at this point a alveolar membrane and then a capillary membrane, those drugs, based on osmosis, are able to be pushed out into the systemic circulation. Now, along with this, not only did we have to give the drug, but we also had to give 2 to 2.5 times of the volume. So if we end up having to give 1 milligram of 1 to 10,000 or 0.1 milligram per milliliter of epinephrine, and we had to double to 2.5 times that down the tube, we're giving 20 to 25 milliliters of normal saline that is mixed in there. Same thing when it comes to lidocaine in 10 mLs. Same thing with atropine, which is usually in 1 ml. Okay, the lidocaine's in 1 ml. So we're giving, you know, a whole bunch of fluid. They found out that this really didn't work. I don't know why it's still in here. I'm sure there are some people that do believe it worked. But now with the advent, you know, getting the IV and getting an IO, we don't have to use it. So if you see an old medic or something like that and they're like, oh, let's dump it down the tube. No, we're not doing that. But just know if you ever hear the term lean or kneel, that's what that meant. Now, there was also another drug that we could give down the tube, and that was Valium. They believed that that was acceptable, and that acronym was NAVEL, N-A-V-E-L. And the reason why they believe Valium, they thought it was water soluble, but in reality, it was. It has a little bit of lipids in it, and that broke down the inside of the alveoli. But that was something to think of. And if you work critical care or work up in a unit or anything else like that, you will find that there are some individuals that will profess to the use of taking an albuterol or a Duaneb and dumping it down the tube. Directly into the alveolar membrane with the positive pressure behind the bag. Please remember, all these drugs behind giving them was positive pressure ventilation along with that, but believe that the albuterol actually removed a lot of the mucus away from the wall and allowed it to be broken up and suctioned out of the tube. Because what respiratory therapists will do with, you know, bronchitis or anything else like that, they will inject some fluid into the lungs, and that will help break things down and do that. So there was probably about a 20-year period where this was acceptable. So when you read that, you know, can be given via endotracheal tube, Ixnay on the tube stuff, okay? IV IOs. All right. Anybody have any questions on that? All right, everybody. Hey, it's 8:16. We've got a lot. You got a lot of reading. Watch the videos, everything else like that. We'll come back next week and do the AMLS case review, and we'll continue on with next week doing some stroke and some stuff too, and some more case reviews with that. So, unless anybody has any questions or anything else like that, I'm going to call it an end for tonight. Give you a little bit of time off for your vacations. Enjoy the holidays, read your ACLS books and your PALS books. I'm still working on trying to get into the college to get you guys ITLS books. And then during this week and next week, I'm going to be working on pulling your precepting files, and that way you and I can at some point sit down and have an idea clinically and in the field where you're at. That way you and I can have an offline discussion on where we're at and what you're going to end up, what we're going to do, and my thoughts on what you need to do once clinical opens back up and be more targeted cherry picking of patients. All right. So unless anybody has any questions, comments, concerns, gripes, my phone's always on. Text me, call me if you need anything. If not, have a good week, and I'll send you via the announcements and email next week's GoToMeeting for Wednesday. See you all next Wednesday, 6 o'clock.
Yeah. Wednesday, not Monday.